even though I can't see you. Thank you for joining for tonight. So I picked menstrual cycle and ovulation just because I feel like understanding the menstrual cycle a little bit more will be helpful either in your fertility journey, but more importantly, just, understanding your own body. And the menstrual cycle is more complex than we actually think it is. So even as a medical student, I think it's a difficult cycle to understand. So hopefully the goal of tonight would be at least that you can kind of walk away with maybe a couple new knowledge points or kind of better understanding of your own cycle, or whether, understanding or learning more knowledge would help you understand whether you need to be evaluated or not if you're having regular or irregular cycles. So we're going to spend the majority of the time kind of talking about this photo. And I think this is a good overview of kind of what goes on in the menstrual cycle at which location. So I think endocrinology is interesting because it is always kind of this feedback loop. So your brain always controls a gland, which in this case is your ovary, which makes hormone and then feeds back to your brain. So it's kind of this whole circular loop. And eventually, yes, there is outflow, with the uterus and the vagina. So, if somebody is having irregular cycles or no cycles, you use kind of that structure to think, okay, the issue could be at the brain, or it could be at the ovary, or it could be at the uterus, or at the vagina. So when you look at this slide, so the top part is kind of symbolizing the follicles that grow in the ovary. This section is a representation of your hormones. So the pituitary gland is a specific gland in your brain that is making the FSH, which is your follicle stimulating hormone, and your LH, which is your luteinizing hormone. And then in the ovary, you have production of your estrogen and also your progesterone. And then here at the bottom, this is a representation at the same time what's going on at the level of the uterus. So the endometrial kind of cycle, the endometrium is the lining of the inside of the uterus that gets shed every month. So one important kind of concept to grasp, and we'll refer to this if you see us for a new consult, and if you're going through a fertility cycle, cycle day 1 is considered your first day of full flow. So some women have kind of a spotting day at the beginning. We don't count that, but cycle day 1 is your first full flow day. And your cycle then ends, in this case, 28 days, the last day before your next cycle day 1, which would be your next full flow. And a menstrual cycle is broken up into 2 kind of phases. You can see right here, this first half is the follicular phase, and the second half is the luteal phase. So everyone's follicular phase can be of differing kind of variation. And that just depends on how fast you grow a follicle and how many days, it takes you to reach the point of ovulation. Ovulation is what separates your follicular phase from your luteal phase. Now, everyone's luteal phase is a set kind of time frame. So from ovulation to your next first day is 2 weeks, and that's a set time period. That doesn't usually change from person to person, and that's helpful because we can kind of utilize that to backtrack when we're talking about evaluation of whether your cycle's normal or abnormal and whether also you're ovulating. So that's kind of an overview. So on cycle day 1, you'll commonly hear us say, oh, you're going to call the office when we're doing a fertility kind of evaluation on cycle day 1. So this is your first day of full flow, and you'll also usually kind of come in for evaluation on cycle day 3. Why do we use cycle day 3? That's because on day 3, your follicles are small, your hormones should be low, and your lining is usually you know, on its kind of way down after the first couple days of heavy bleeding. So what's going on? So at this point in time, you're kind of, you know, early menstrual cycle, your lining's shedding. You may see fluid in the lining on ultrasound. Your FSH, estrogen, and LH should all kind of be on the lower end, and your follicle is smaller. So follicles are fluid-filled sacs. So they're like a cyst in that they're fluid-filled sacs, but there's a microscopic egg in each one. When we are seen on cycle day 3, it would be normal to have a handful of follicles in each ovary, right? Sorry about that. So with that, only one gets picked every month to grow, right? So a normal kind of follicle count would be 6 to 9 follicles on each ovary. Now, women, for instance, with PCOS may have more follicles. Women with low egg count may have less follicles. One follicle gets selected as the dominant follicle, and that's the one follicle through very complex mechanisms that grows, right? Because in each of our menstrual cycles, if we're ovulating, we're only releasing one egg. So as the follicle starts to grow, it gets bigger in size. So if we do our ultrasound measurements, we can measure the diameter, it gets bigger and bigger. As the follicle grows, it starts to produce estrogen. And you can kind of see this uptake in the estrogen line here. Right before you ovulate, this follicle, if we were to measure it on an ultrasound, is probably about 2 to 3 centimeters. So it's pretty decent size. And at this point in time, you can kind of see here your lining in your uterus, you've completely shed. Now from the high estrogen, it's starting to grow and build up, okay? So with the thicker lining and the larger follicle and the higher estrogen, the estrogen at this point, remember I said it's all kind of this feedback loop, feeds back to the brain and triggers what we call our LH surge. So our LH surge is a hormone released by the brain that then triggers the ovary and this follicle to ovulate. So ovulation just means the follicle ruptures and the egg's released. So this LH surge triggers this, okay? Once the egg is released, let's say you get pregnant, okay? This follicle hangs around and is actually producing the majority of the estrogen and progesterone until your placenta kicks in around kind of 8 to 9 weeks pregnant. If you're not pregnant, right, the pregnancy hormone can't help preserve this follicle. So this follicle starts to kind of shrivel up. You can see it here. It's called the corpus albicans. And when this follicle starts to kind of shrivel up and collapse, it can no longer make progesterone. So you get this drop in progesterone here. This big drop in progesterone and this big drop in estrogen is what triggers then your lining to shed. And then you start kind of the entire cycle all over again. So it's helpful to review that cycle because how do we utilize it? We utilize it in many different things in many different ways. One way is ovarian reserve testing, right? Why do we care about how many follicles we have in the menstrual cycle? Well, we care about that because one big difference between men and women is that, you know, men have the ability to constantly make new sperm. However, we as women are born with the number of eggs we have. So we have at birth the most eggs we're going to have, and our egg count slowly declines. When we hit kind of our mid to late 30s, we see this decline in egg count occur at a more rapid pace. So, you know, at puberty, we probably have 300,000 to 500,000 eggs left. By the time we hit menopause at 51 on average in the United States, we probably only have 1,000 eggs left. Now, they're not good eggs, but they're there. So if you calculate it, if you are, you know, calculating how many menstrual cycles you have from puberty to menopause, it's probably around 400 to 500. So, you know, those are 400 to 500 eggs that you ovulate, but there are many more kind of eggs that are constantly undergoing cell death. With this drop in egg count, we also see an increased risk in miscarriages. And that's just because our egg quality also declines. So there's a couple tests that we'll do to help you check egg count to get an estimate. They're not perfect tests. They're not going to give you, we're not going to be able to say, you know, you have 3,002 eggs left, nothing like that. But we'll be able to say, you know, your egg count's average for a 35-year-old, above average or below average. And part of that is related to your menstrual cycle itself. So if you were to kind of backtrack here, we always have you come in around day 3. Why here? Well, one, part of the assessment is counting how many follicles you have on the ultrasound when they're small, okay? 2 is getting this day 3 FSH. Why do we care about this? Well, remember, the brain controls the ovary. So if the egg count is low, right, we may not be making that much estrogen. But think of the brain really having to work hard to get that ovary to respond. So I always say it's like the brain kind of yelling at the ovary, pick up the pace. So your FSH goes up when your count is low. And that's why we get these kind of day 3 assessments that you'll hear us talk about, because it's all based on the menstrual cycle. The third test that we do is not necessarily based on the menstrual cycle, and that's the AMH, or the anti-Müllerian hormone. That is actually, the nice thing about it is it's actually not cycle dependent at all. So it can be drawn at any point in time in the menstrual cycle. We tend to draw it on day 3 just because you're coming in around that day. And that is the opposite of FSH, right? So when your egg count is, you know, when your egg count is low, your FSH is going to be high. AMH is made by the cells around the egg. So the more eggs you have, the higher the AMH. So when your counts are low, you would have a low FSH, a high FSH and a low AMH. Okay. So what's a normal cycle? And that's a common question I will get all the time, right? And why? You know, you should almost think of your menstrual cycle as a vital sign. So you commonly may, you know, when you go to your primary care doctor, they're going to take your blood pressure, your temperature, and the nurse or the MA will probably say, okay, when's your last menstrual period? Same thing with your OBGYN. We use the menstrual cycle essentially as the vital sign because it gives us a lot of information, right? A normal cycle, you know, is considered anywhere kind of from 21 days to 35 days. So when I say these day intervals, I'm meaning from cycle day 1 to the next cycle day 1. Okay, that's what when we say cycle interval means. So normal cycles would be 21 days to 35 days, but it shouldn't vary more than 3 days. So for instance, if I said, okay, this month I had cycle history of 30 days, the month prior, 28, the month prior, 29. So I have normal cycles, you know, because I'm within the kind of 21 to 35 days, but I'm also not varying more than 3 days. Let's say I had a patient come in and said, and we pulled up her cycle history. And the nice thing about cycle histories is, you know, they're so easy because there's all these kind of nice apps that you can kind of track and help you track so that when you go to the doctor, you can kind of pull it up on your phone and show us. So let's say, 1 month, my interval was 30 days, the next day 45 days, the next 35. Since that interval is more than 3 days, I'm probably not consistently ovulating. That would be kind of an abnormal cycle. So when you are missing months, right, or when your interval kind of falls out of those recommendations, we would say that you may have anovulatory cycles. Anovulatory cycles just meaning your cycles, you may not be ovulating. Another term you'll hear us describe it as abnormal uterine bleeding, right? The most common cause of anovulatory cycles, at least in the United States, is polycystic ovary syndrome. I think Dr. Sabouni had a talk with you regarding this topic kind of earlier in the month, right? It doesn't have to be polycystic ovary disease or syndrome. You know, when you think back to the menstrual cycle, right, that the brain controls the ovary and it feeds back to the brain, and the outflow tract is the uterus and, you know, the vagina. If you're having irregular cycles, it can kind of be an issue at every single level, right? So is it an issue at the brain? Is the brain not properly stimulating the ovaries, right? Sometimes we see that, you know, for instance, with high prolactin levels, with altered thyroid levels. You know, when you think of the athlete triad syndrome, think of gymnasts or, you know, long distance runners, they're running so much with that stress on your body. You know, your brain doesn't properly stimulate your ovaries, and most of those women don't have menstrual cycles at a regular interval. Could it be an issue at the level of the ovary? Could my egg count be, you know, much lower than expected? And if I don't have eggs to ovulate, I'm not going to get regular menstrual cycles. And then could it be an issue, you know, at the level of the uterus, right? So if I have scar tissue in my uterus, I may not be able to build up a lining to even shed to get kind of a cycle. So when we hear a patient who has irregular cycles, in our mind, we're kind of, that's where the history may help you guide, you know, if someone's had surgeries before, or, you know, if they've had, you know, a stressful life event, or if, you know, they have symptoms of thyroid disease or high prolactin, like milky discharge. That helps guide us in kind of a separate workup that we do, which I bet Dr. Sabouni kind of talked on a fair amount. So that at least guides us into kind of the next question. So how do we know if we ovulate, right? So, you know, for me, I think history is very helpful. Because if a patient tells me they have regular cycles, meaning they fall in that 21-day to 35-day window with not varying more than 3 days, 90+% of those women are ovulating, okay? So history helps me a fair amount. Now, there are some other tests that we can do, and some of them you can do on your own to help you kind of gauge whether you're ovulating or not. But first rule of thumb, you know, looking at your, you know, your menstrual tracker, that will give you a huge amount of information to determine whether you're likely ovulating or not, meaning releasing an egg. Because the important thing to remember is your periods are a reflection of ovulation. So if you're ovulating on a regular basis, you're getting a period on a regular basis, right? If you're not ovulating, then you likely are not getting a period on a regular basis. Now, you may be getting bleeds every once in a while, but they're what we call anovulatory bleeds, meaning it's to the point where the lining of the uterus just grows, outgrows its blood supply, and then just kind of sheds, not as the result of bleeding, but just because, think of it like overgrowth, right? So here's a kind of a couple things. So things that you can do on your own. So this is kind of a basal body tracker, temperature tracker. So basal body temperature tracking can be kind of cumbersome. You most definitely need a specific thermometer because you're trying to catch very small changes in temperature. So it has to be specifically a thermometer to track ovulation. And you're taking your temperature at the same time every single day. And it has to be before you get out of bed, before you take a sip of water, before you brush your teeth, before you do anything. Because the change you can see here is very subtle. So normal kind of average temperature for a lot of women is kind of around 97, 97.5. And you're looking for a trend, right? That's going to, be in the 98 range, right? One kind of thing is that what makes your temperature rise is the rise in progesterone. So this is similar to the graph we saw in the very first slide, which I think is helpful to kind of have right here. So the top line is the hormones released from the brain, right? It's still separated in the first cycle phase, which is the follicular phase, and the second cycle phase, which is the luteal phase, with this being around ovulation. So you see your LH surge right here at ovulation after your estrogen surge. And then you see this progesterone, right? Your progesterone rises in that second half of the cycle. So it's actually the progesterone rise that causes your temperature rise. So the only downside with that is the fact that when you're tracking your temperature, you're going to get a rise after you've already ovulated, right? Because remember, ovulation is here and your progesterone rise is here. So it may be helpful for you kind of tracking ovulation in the next cycle, but not necessarily helpful that cycle because you've already ovulated. So I usually don't have patients, utilize this because it's a very cumbersome kind of tool to use, right? Cervical mucus, kind of same thing. So all of us, secrete some, cervical discharge, vaginal discharge, and the cervical discharge changes where you are in your cycle. So at the beginning of your cycle on day one, you're not going to have much cervical mucus after you, finish bleeding. Towards the, half point right here in the first cycle, right? Your estrogen's growing up and increasing. That's going to cause kind of that thicker, whiter cervical discharge. Right here around ovulation, your discharge almost becomes a little more watery with a little bit of stretch to it. So you can kind of think of, you can stretch it within your fingers. So think of clear, uncooked egg, right? Egg white. And then that's kind of a marker of ovulation. But I think that test's a little difficult and some people aren't comfortable, with collecting their own cervical mucus and looking at it. Probably one of the common, tools that patients use is this LH kit here, right? So these are sticks that you urinate on, right? And what it's doing is it's picking up your LH in your urine. So when you get this LH surge right here, which triggers your ovulation, from LH surge to ovulation, it's about 36 hours later. It's going to take a little bit time to get the LH surge in your blood to kind of spill out in your urine, and then you ovulate, right? So this is exactly what it's picking up. It's picking up the LH surge that's made it to your urine, okay? And ovulation usually is kind of the next day. So your most fertile days are actually, the day that you're getting the surge, and actually the 2 days prior to ovulation. Why? Well, the egg only lives 12 to 24 hours, but the sperm live 3 to 5 days. So that's why the 2 days prior to ovulation are technically the most fertile days. Now, the kits are probably the most helpful in somebody with regular cycles, right? Somebody with irregular cycles or somebody with PCOS, these kits can be notoriously inaccurate, okay? So I will kind of place that as kind of a warning sign. So for instance, if someone says, oh, I'm getting positives on kits, so I think I'm ovulating, a good kind of way as a check to ask them is I'll say, okay, where do you get the positive on the LH kits? And then when do you get your period? If she says, well, I get my LH surge here and I get my period 2 weeks later, well, that's probably pretty accurate. That makes sense, remember? Because from the ovulation to period, that doesn't change. That's about 2 weeks. And we can pick up the LH surge in the blood. It's just we usually sometimes will happen to do that when we're in a treatment cycle. The gold standard for detecting ovulation, though, would be checking this progesterone level in your blood. Okay, so you will commonly hear us say, or you'll have a doctor say, maybe your OB/GYN says, I'm going to get a day 21 progesterone. So we're checking this progesterone level. A progesterone level above 3 tells us you're ovulating. And it's not, it's not an issue of a level. Like okay, if I have a level of 5, does that mean I'm ovulating less? Is there a way to partially ovulate? No. So anything above 3 tells me you're ovulating, okay? The only thing to kind of take note of this is this should be drawn about a week before you normally get your period. So we all kind of standardize on all these graphs. You'll always see kind of 28-day cycles. So that's where we get the 21-day progesterone, right? Because you're just drawing it 1 week before your period. So somebody with with regular cycles that are a little bit longer, like let's say I have a patient who has super regular Q34-day cycles, right? If I draw a day 21 progesterone, I may think she's not ovulating, but in fact, I'm just drawing the test too early. So the test does have to be kind of altered to fit your cycle. But a good way of doing it is, hey, we need to draw this blood test about a week before you get your period, and that'll tell us if you're ovulating, right? So that opens up to Q&A. I'm going to kind of go back to this page because I think this page is kind of the most helpful, and hopefully, the menstrual cycle I think is super complex and confusing even for, medical students and physicians. So hopefully I explained it in a manner that, you're able to understand some and able to at least take away with a couple new knowledge points that, you learned that you can apply, to your own history, or also, when you should be evaluated for fertility. Because, usually we say, come see us if you've been trying for a year under 35 or 6 months over 35. But that should be sooner if we know there's a fertility issue. So if somebody has irregular menstrual cycles and they're not likely ovulating or consistently ovulating, they don't need to wait the full year or the 6 months. I'll always tell them to come in early, okay?